So, good evening, all. Myself, Dr. Kiran Varma, working as head of the department, Yashoda Hospital, Malakpet. So, I welcome you all on behalf of Yashoda Group of Hospital for this series of webinars connected by Emergency and Critical Care Department on alternative Tuesdays. So, today we have come up with an interesting topic, pediatric emergencies, the ways to deal. So, for this topic, we have divided the content into two parts. One is stabilization at primary hospital and during transport, which is going to be dealt by senior most pediatric specialist, who is a pediatric care specialist as well, Dr. Suresh Kumar. I welcome you all. Welcome you, sir. Then second content is stabilization of sick child in emergency department, which is going to be dealt by Dr. Suresh MVN, HOD emergency department at Somajiguda. So I welcome you, Dr. Suresh. So I welcome you both. So with this brief intro, so I welcome you both. Then I hand over the mic to Dr. Suresh.
Good evening, everybody. At the outset, I would like to thank Dr. Suresh, who is another Suresh, who has come up with this idea of involving both critical care as well as emergency medicine, because they both are hand in hand. So it's a nice way of getting to know a lot of people. And then we thought we will connect it from the referring hospital to ER to PICU. That's what we thought. We will make it something little interesting. So with this brief background, I would like to start off with my presentation without wasting much time. So today we'll be dealing with the transport of a critically ill child and then stabilizing the child at the referring hospital. Are my slides moving, Dr. Kiran?
Yes, it's moving.
Yeah. This is my life journey. Started off in Manipal and then now back to Hyderabad. And now, right now, I'm in Yashoda, working as the lead consultant, pediatric critical care and pediatrics. So at the outset, there are no conflicts of interest, and I would like to acknowledge all the patients through whom I have learned, and then who are teaching me, and I'm continuing to learn from them. Then we will just see a brief case scenario, and then we will go into components of transport and how to go about stabilizing the child. If you look at a very common scenario, a 3-year-old boy admitted to XYZ hospital with bronchopneumonia and respiratory failure. Child was rightly so intubated and ventilated, was being managed on conventional ventilation. On second day of admission, child started requiring 100% oxygen with a FiO2 of 1 and pretty high pressures, and also developed CO2 retention. At that particular hospital, there is no high frequency oscillatory ventilator available, so they wanted to transport. This is a brief scenario. Most of us will come across either in a similar way or in a slightly different way, that one or the other facility might not be available at that particular hospital and they would like to transport to us. So how to go about? What next? So we need to either transfer the child or transport through a specific team. So there are 5 components of transport: why we should transport, when we should transport, how we should transport, who should transport the baby, and where should we transport the baby. If you look at these 5 components, which we will do in next few slides, most of the questions should be answered. When to transport or transfer? If you look at the previous scenario, it is beyond the capability of the unit to have a high frequency. That's the reason one should know their own limitations, and they should also know the resources which are available to them. So depending on the resources which are available at the treating hospital, then they should take a call on transporting the child. So most important is anticipating. We should not wait till the child deteriorates. We should anticipate and then be prepared for that. And why should we transport? So that the advanced care can be initiated timely and for the better safety of the child. So where to transport? We should also know our limitations, and in addition, we should know the facilities where those limitations are rectified. Say, for example, in the previous scenario, the XYZ hospital did not have a high frequency ventilator. So we should know the person working there should be aware of the facility where such HFO is available. So they should have more than one option, because if we keep only one option and that particular option is full, then they'll be stuck. And who should transport? There are 2 ways of transport. One, the unit-based transport system, or the other one is dedicated specialist transport. So we should look at the patient needs and then the composition of the team, which should involve a pediatrician or a ER specialist and an appropriately trained paramedic and nurse and the support staff like the driver, ambulance driver, who should be able to pitch in and help. And each one of us should be knowing our own responsibilities and roles while going for a transport, because after going there, we are going to be in a war zone. We are all together in a new place. So we should be very clear in our roles and responsibilities. How to transport? Depending on the place where we are working, right now, even air transport is pretty much available in Yashoda. So we should know from where we are going to bring the baby, how we are going to transport. So there are two ways. One is road transport or air transport. The critical steps which are necessary to select the optimal mode of transport is looking at the patient's current status. For how long do you think child is going to give us some time? And then what is the care that is required during the transport? Some of those things might not be possible in road or air. So we need to look at it. And what is the urgency of the transport? If it is a very dire situation that the child needs to be transported pretty quickly, we cannot depend on the road, because we all know Hyderabad roads, when it can get stuck, we do not know. And the logistics of the patient transport needs to be taken into consideration. Being prepared definitely pays off. So checklist. This is what we keep telling our residents. So we need to thoroughly go through the checklist, and dedicated team should be there, ambulance and the driver, and the transport kit needs to be checked daily and before every transport. During transports, we should not have a confusion of roles and responsibilities. We should be ready for troubleshooting. And after transport, we need to hand over at the destination hospital appropriately. Now, if you look at stabilizing the child at the referring hospital, I'm going to show a few slides with the images. We need to check the airway and secure ETT. Even if the child is intubated and even if the referring doctor says that it is appropriate, there is no harm in checking the chest X-ray and then again examining 5-point auscultation, and then if required, re-secure the ET tube in an appropriate way. Most important is if the child is intubated already, it's advisable to give vecuronium or some sort of muscle relaxant to keep it safe during transport. Always advise the referring hospital to keep the child nil by mouth for at least a few hours prior to transport. We need to have at least 2 working intravenous access. If IV access is difficult, secure a intraosseous. I'm going to show a slide on that. And then check the blood glucose before getting into the ambulance, and then check CNS, that is pupils. If it is herniating, you might have to do appropriate measures before even getting into the ambulance. And then all investigations, including the radiographs and drug charts, need to be carried. And then discharge summary or a transfer summary, if it is prepared, that should be carried. So for a brief transport, sometimes we can rely on supraglottic airways like laryngeal mask airway. But if we are looking at a long distance transport, this is not a very safe one. This does not altogether prevent aspiration. This is good enough for a short period of time to tide over the crisis. But if it is a very short transport, intra-hospital or very nearby, and the child otherwise is stable and definitely nil by mouth, probably a good way. But otherwise, this is not a great airway to have for a long distance transport. A pediatrician's nightmare is an IV access. If we are in a referral hospital where we do not have facilities to get a central line or something like that, and child is already in shock, do not move without 2 wide bore cannula. If not a cannula, at least 2 wide bore intraosseous. So now with the availability of easy IO gun, it's pretty much easier. I'm not going to details of how to secure an intraosseous. There are various options depending on the place where we are going. Have a easy IO, let's not complain. We can secure with a bone marrow aspiration needle. But if it is available, easy IO is the best one because it can secure very well and then can be used for at least 24 hours. And these are other equipment which are very useful while we are traveling or for transport, because if child has already developed pneumothorax and is being transferred to our tertiary care center for further care, we cannot use underwater seal, especially if you are flying. Even by road, it's sometimes going to be a very tricky thing. So this is called a Heimlich single way valve, which is very useful to drain pneumothorax. This is a single way. It does not allow the air to enter, but it lets the air out. So the last image, and this is how it works. functioning of Heimlich valve. Somebody has not seen, worth having a look at it. And then this is something which is very important, not often talked about in Indian scenario, communication. If you are at the referral hospital and if you are talking to your consultant who is at the tertiary care center, keep the conversation very crisp. This is what we train everybody: SBAR, situation, background, assessment, and recommendation. This SBAR communication should happen from doctor to doctor, nurse to nurse, and then doctor to the family. And then most important thing is documentation. Do not forget documentation. You should take consent for the transport, contact details of the parents, because we might not be allowing all the parents or the entire family to come with us. So at least one person will be allowed with the child in the ambulance. Rest of the family members, we need to take consent. And if you are talking to a new consultant in the tertiary care center, we need to introduce ourselves and then tell him briefly what is the situation, what is the background, and what is your assessment at the time of examining, and then what do you want the consultant to tell you, whether you are okay to move or stabilize further, and then ask if there are any further questions. And then this is a classic slide: document your communication and communicate your documentation, because you better spend some time in communicating and documenting that communication rather than going around the codes. Palest ink is better than the strongest memory. That is, we might remember today, but 3 months later, we might forget half, and 3 years later, we might altogether forget. That's when a medical legal case arrives. And then during transfer, there are certain things we need to take care. That is, you have already secured the ET tube and you have muzzle relaxed the child, but do not forget connecting to ETCO2, because during transport, if there is a slight dislodgement of the ET tube, the first thing that's going to tell us is capnogram. Do not wait for the vitals to drop to pick up that child has been self-extubated. So continuous hemodynamic monitoring should be connected. ETCO2 should be connected, and the blank line which I have kept is going to be highlighted, that never silence the alarms during transport. Very often we tend to get annoyed with the sounds of alarms and then silence it. Never silence the alarms, because it is giving us a vital information which we might not pick up otherwise clinically. So having a capnogram, continuous capnogram, is very, very useful while transporting a child. And then these are other accessories which are useful for a short distance. These are specific cylinders for a short distance transport. And if we are having Jackson-Rich circuit and then we are bagging the child on the way back to tertiary care center, ensure that you have checked your oxygen cylinder capacity. And then if we are flying, we need to take certain precautions. Who is leading the team? And we need to adjust the oxygen to altitude, and we might have to check blood gas at the base and then at the peak while we are in the air. Okay, after reaching the highest altitude, we can check using an iStat in such circumstance, which help us. So some of the alternatives during transport, I'll show you a couple of transport ventilators, carrying oxygen cylinders, and then checking the capacity and having an appropriate suction, and then Heimlich valve if air leaks develop, and then always remember our mantra DO. In case of acute deterioration, our mantra is DO: displacement, obstruction, pneumothorax, and equipment failure. So at the referral hospital, check the airways, and then all the access should be checked, and then hand over all the investigations and then drug chart to them, and then document what we have done before transport and after transport also. And do not forget to communicate with the family. My take-home messages is always know your limitations, and no one is complete. If we are in trouble, ask for help. Know your facility. If you do not have a certain facility, it's always good to know it well in advance rather than trying to find out at that time. And always expect the unexpected. This is what happens in our medical field, especially in emergencies. And then always be prepared for a trouble which you are going to anticipate later. Communication of documentation, documentation of communication is to save yourself. With this, I would like to stop my presentation and then back to Dr. Kiran Varma.
Thank you, sir. That was really a good talk. It's informative, informative as well. Thank you, sir. Now I'd like to welcome upon Dr. Suresh MVN to talk about next content. Suresh, sir,
yes, sir.
Please take out the mic.
Pawan, can you start video?
Yes, sir, you can share the screen.
Yep, fine. Okay, yep. Is it audible, Pawan?
Yes, sir.
Yeah, fine.
Go ahead.
Yeah, thank you, Suresh sir, for your wonderful pep talk. And that was a very nice and informative talk. Now, I would like to, 1 second, please. Give me 1 minute, there is a technical glitch.
Please reshare it, sir.
Yeah, just Can I?
Yes, sir. Good to go.
Yeah, fine. Yes. Yeah, good to start. Yeah, thank you, sir, Suresh sir, for the wonderful and pep talk on the how to transport a sick child or any child which we are going to receive. Now, come onto the floor. So we are going to deal with the. We have received the child, and then how we are going to stabilize in a systematic manner. We are going to learn over the next 15 to 20 minutes. So what we are going to talk, stabilization of a sick child. Is it like, are we treating the child as similar to adults when we receive a sick child? Absolutely no. There are certain essential factors which we need to know before dealing with the children. So they're not just like little adults. They're not just like little adults. Are you going to give the half of the dose of any of the adult dose? Absolutely no. You need to understand that few essential factors are there while dealing with the children, okay, in the emergency room. So you need to understand the physiological and biochemical differences so that you can treat them appropriately. And you need to be familiar with the different equipment, drug doses, as well as the procedures. And it is also essential to empathize with the child family. Of course, you all know that parents will be apprehensive when they are bringing their child and exactly they don't know what's happening with their child. So how the first starts with the preparation. How you are going to prepare your ED? You need to have the pediatric friendly zone in the ER. Why? You can keep a small balloon or a soft tie. Suppose if you're going for a cannulation or sample collection, you need to distract them. So have a separate bay in your ER, okay, which is separated from the adults, and you can draft your child-friendly ER by placing a toys and then your play items and all those. Sick child. So where I'm going to keep the sick child? Either you can keep it your research room or a theater or any sick bay, okay, or in PICU. There you can keep the sick child. So what? Major causes of cardiac arrest in children, if you see, they are due to the respiratory failure and shock. And again, child went into the cardiac arrest, and then chances of survival and discharge after resuscitation, they are very much greater if you perform your resuscitation early, so that okay, you can lessen the morbidity and mortality. So what happens really? As due to the respiratory failure, they tend to have the hypoxemia, which results in the hypercapnia, and which can lead to the acidosis and then bradycardia, hypotension, and then secondary cardiac arrest. So what we are going to have? So you need to give the medication. Yes, of course. You need to start the medication. What do you want to know? You need to know the proper doses in children. You need not have these everything on your fingertips. Either you can just have your apps, or otherwise you can have your BNF formulary or any Indian pediatric book, okay, so that you can need to calculate the weight of the patient first, and then knowledge of the dose for the error-free calculation as well as the delivery. And to calculate appropriately, how to determine the child weight. There is a length-based estimation, age-based, and healthcare provider estimation if you are in a secondary setup. And there is a, if you are really attending the sick child, there is a wet flag, which you need to know, all of you, as an emergency physician or a critical care physician or either a pediatrician. When you're really dealing with the sick child, you need to have the calculation of this wet flag. Suppose if you are receiving a child, a sick child, you have a pre-arrival notification. Okay, prior itself, you need to calculate the wet flags for the child as per the age, and you need to keep yourself ready. Equipment, yes, it's important to have your equipment ready and very easily available in your ER. That ranges from your resus cart, which can be drafted as per the pediatric age group, as well as the stride blades instead of, curved blades. IO access, of course, if you have the proper pre-hospital care setup, you tend to have the IO access in situ, as Dr. Suresh sir said. Rather, but if not, then you need to have the equipment ready, like IO access, which I'm going to show, EZ-IO or bone marrow needle, for the delivery of the IV fluids, as well as the drugs, as well as the inotropes or the blood products. And in it, one of the important aspect here is Broslow tape. Every emergency need to have this, okay? So that if you keep the child on the bed, then simply you can measure the height and appropriately have everything, including fluids, doses, and everything. Preferably straight curved ET tubes, okay? You need to proceed. Okay, I have received the child. How I am going to assess? This is very important. General assessment. Initially, you start with this. You need not touch the child, just by appearance, by your tickles, and then work of breathing, whether the sniffling position or whether labored breathing, that you need to see. Circulation, quickly see the child, whether it is the pale, mottled, or cyanotic. Quickly, you can assess whether the child can be triaged, into the priority 1 or priority 2 or priority 3. And then your primary assessment, there is a systematic approach here, dealing with like ABCD concept, it's which I'm going to discuss in the next slide. And then your secondary assessment, which involves the focused physical examination and your sample history, as well as the bedside glucose. Ultimately, you need to put the diagnosis, which we rely on the radiology as well as the lab investigations. Triaging, yes, as I said, like this is the part we call pediatric assessment triangle, which has a high importance. Just as soon as the child arrived, just observe the appearance, breathing, color within few seconds. Then I can quickly triage and I can identify the general physiological problem, whether it is due to the breathing or circulation or airway, and then uh, you can deliver urgent treatment if it is required. As I said, you need to proceed the management in a systematic manner, A, B, C, D, E. If you have a problem with A, B, or C, just please fix there. Okay, before don't proceed to D and E. We start with airway. Yes, anatomy of the airway is compared to of an adult is different to child. If you see the child, they have the larger tongue, and you have a larger epiglottis as well, and there is a narrow cricoid, okay, and your trachea is narrow, and then it is very less rigid. All these factors you need to keep in mind before dealing with the airway of the children. Positioning, yes, you can do head tilt, chin lift, jaw thrust, and then we can maintain the sniffing position. Just put a towel under the shoulder, that you have the better view of the airway. Uh, Before the proceeding for advanced airway, just you can try with NPA and OPA. But only the thing is, while putting NPA, please be aware that you need to prevent the nasal trauma. While OPA you can use for any unconscious child. So coming to classification, how we are proceeding. So as soon as I'm assessing the airway, we can keep the three factors here. We can classify into unexpected airway, suspicious, and anticipated. Unexpected here is a child is stable, no predictors of difficult airway. There are no signs of respiratory distress history or recent respiratory problems. Then you said that airway is stable and then you can relax. But suspicious airway, yes, there are some signs and symptoms of respiratory distress, labored breathing, low SATs, history of recent respiratory illness like asthma, broncho-obstructive syndrome, and there are secretions pooling up which you are not doing suction. I mean, proper suction was not done. Then you need to think of suspicious airway and deal accordingly. Anticipated, yes, there are in trauma, especially there are anatomic disruption that compromise the airway structures. That includes the face, oropharynx as well. There you can face the difficult airway. If you classify airway obstruction, you can see anatomical as well as functional, how you are going to deal with. If it is a malposition of the head, just align the three axes, okay, stabilize the head with halo ring and then a pillow under the shoulder, then you can proceed. Tongue obstruction, I think rather you can put NPR, OPA. If there are face mask ventilation issues, just fix the proper mask size and then adequate seal and then proceed. Foreign bodies, yes, try to aspirate if it is visible under direct laryngoscopy vision. If not, oxygenate and then seek the expert consultation. Yes, you observe the laryngospasm. What you are going to do? You need to give the adequate plan of anesthesia that you are going to achieve with the IV agents as well as the muscle relaxants. Here we have atropine here, which has a role in the pediatric age group. It was proven that you can give atropine along with the succinylcholine, and later you can paralyze with the rock. Functional, yes. If it is a muscle stiffness, then you can give the positive pressure ventilation, and then you can oxygenate with the 100% oxygen along with the muscle relaxation. Yep. Coming to breathing, yes, you dealt with airway, then coming to breathing. Just simply, it involves the measuring your SATs, respiratory rate, and then observe the breathing pattern and auscultate the chest. Yes, you think like breathing is not appropriate. Then you can proceed with starting of 100% FiO2 with your RBM. And then if not, then you can try the back wall mask. But make sure that you children have the minimum of 450 ml of ambu bag. Breathing, yes, again, I'm going to stuck up here. So what is the cause of respiratory distress or failure? Then you can classify this as the pulse, basically. Now you can classify as upper airway obstruction. What I'm going to see here, there is a stridor, snoring, there is audible noise here. So you can quickly assume that child might have croup, anaphylaxis, or aspiration of the foreign body. Then you need to dealt appropriately. Croup, I think all of you know, you need to give the epinephrine as well as the corticosteroids, IV steroids. Anaphylaxis, I think if the child is in shock, then you need to proceed with IM epinephrine, then nebs of albuterol, antihistamines, and then corticosteroids. Yes, you are suspecting lower airway obstruction. What you're going to do? Then again, you might suspect the bronchiolitis. All of you know that you're not going to much to do with the bronchiolitis acute. You need to do the nasal suctioning and then just consider the bronchodilator trial. Asthma, I think all of you know, not too much emphasize on that. You need to start with bronchodilators, then steroid, then max sulfate, then terbutaline. Okay, and then you can try the IM epinephrine if it is really severe. Lung tissue disease, this comes into two categories. Yes, pneumonia or pneumonitis, which is very common now. Again, you need to give the antibiotics here if you suspect pneumonia, and consider invasive or non-invasive ventilator support here. Yes, pulmonary edema. Yes, this is another entity. You need to classify whether it is a cardiogenic or non-cardiogenic. If it is cardiogenic, please consider diuretic. If it is non-cardiogenic, just NIV or invasive support with PEEP, and then consider vasoactive support as well. Disorder control of breathing, yes, of course. So here again, three factors involved: increase in ICP, that is head trauma. Here again, what are all the how you are dealing with the head trauma? I mean, traumatic brain injury. You need to apply here. Just simply avoid hypoxemia, avoid hypercarbia, and then avoid hypothermia, and then avoid hypotension. That is going to take care of the child. Poisoning, exactly. You need to give the antidote for the reversal of the respiratory failure phenomena. And the neuromuscular disease, yes, you need to consider the NIV or invasive ventilator support. Yes, we have dealt with A and B. Then coming to circulation, again, you need to quickly see the child, whether pale, mottled, or cyanotic. Quickly try to establish an IV axis. You need to start the IV crystalloids at the earliest to correct the hypotension. That in turn correct the acidosis. All right, circulation again. It's a shock. Yes, you again the child presented with is paler, then you are thinking like a child in circulatory shock. There are various factors here. Again, hypovolemic, you need to see whether it is a hemorrhagic or non-hemorrhagic. Non-hemorrhagic, again, it could be severe gastroenteritis, all these. Then you need to just give the IV crystalloids, 20 mils of bolus, okay, and then repeat as needed. Hemorrhagic, exactly. you need to control the external bleeding and then transfuse PRBC after initial trial of IV crystalloids. And then distributive shock, yes, there are three factors here: septic, anaphylactic, and neurogenic. Septic, again, you need to follow the septic shock algorithm. I think all of us know that golden hour concept. Anaphylactic, you need to give the trial of IM epinephrine, okay, along with other supportive. Neurogenic, you need to consider the vasopressor here. Cardiogenic shock, I'm not going to much emphasize on the bradyar tachyarrhythmia algorithms, which you are going to learn in the pulse. But other, yes, you need to look at the congenital heart disease, myocarditis, or cardiomyopathy. Here, you need to start the inotropic or vasoactive infusion, and please involve the expert at the earliest. Obstructive shock, again, cardiac tamponade and tension pneumothorax, these are within the periphery, purview of the emergency or critical care physician or pediatric intensivist. Just you need to correct it with the tube thoracostomy, preferably nowadays. And then cardiac tamponade, if it is a cardiac tamponade, you need to perform the pericardiocentesis, preferably under ultrasound guidance. PTE, exactly, consider thrombolytics as as at the earliest. And then ductal dependent, if you suspecting LV outflow obstruction, then consider prostaglandin E1. Yes, I do have a peripheral axis. I don't have a central axis. What is the inotropic of choice? You can start dopamine, okay, at 5 to 20 mics per kg per minute. For that, you need to dilute in 5% dextrose till you get the central line in place. Of course, adrenaline, noradrenaline, dopamine, these are preferably to be administered centrally. Disability, yes, we do have scores here. You need to, if you can't memorize like a GCS, of course all of us are familiar with the adult GCS. Pediatric, again, there is a confusion. You do not have that in your mind or in your brain. Just refer to the pediatric GCS, which you can paste this at your pediatric ER, pediatric zone, ER zone. Otherwise, simply rely on AVPU, that is alert, verbal, pain, and unresponsive, and then quickly you can just proceed accordingly. And again, as well, you need to check the pupil response to the light, as well as you need to check the BM, that is GRBS. Exposure, again, it involves the detailed head to toe examination. But in the pediatric age group, please see our presence for the petechiae purpura. You need to have the meningococcal septicemia in mind, okay, while dealing with any child with rash. If it is any unusual petechiae bleeding or markings, then you need to consider NAI. Okay, I have completed my primary survey, but again, you couldn't able to fix the problem. So what you are going to do during the primary survey? Again, you need to restart from ABCDE where you have missed. And again, you need to track exactly what the problem which was there, and then you need to act accordingly. After that, you need to proceed for the secondary survey, which involves sample, which you can get it from the parents, signs and symptoms, allergies, medication, past medical history, last oral intake, as well as the events leading to injury. Yes, you have done everything. So you are going to give the child to PICU. So what you have done? Again, you need to re-emphasize on your current clinical status. Again, starting from airway. So what you have done, if it is a airway stable, it's okay. But if the child was intubated, then you need to document everything. ETT size, length, cuff, grade of laryngoscopy method, and then if it is a trauma, then C-spine, you need to, whether you have cleared it or not, then you need to mention it. If it is breathing, yes, you need, if you start on ventilator, then you need to document everything like mode of ventilation, what you have started, SpO2, EtCO2, and then nitric oxide, if you have if you have used as the induction, then you need to mention that also. And most recent available blood gas result, you need to mention it. Circulation, again, you need to, your general heart rate, BP, map, cap, refill time, and the urine output, how many fluids you gave, any inotrope support you have started, that you need to mention. Disability, yes, what is your GCS, otherwise AVPU score, whether the child was sedated or paralyzed, pupillary reaction, or if you have given any 3% saline or mannitol, that you need to mention. And any other adjuncts like you have put the NG tube, OG tube, or your urinary cath, that you need to mention. Finally, what you have put the working diagnosis, that you need to mention. Monitoring in ER is always like you need to monitor ECG, that is cardiac tracing, SATs, NABP, or your arterial blood pressure, and end-tidal CO2 if the child was put on advanced airway. And your targets, what are the targets? Like you need to maintain SATs around above 94 always. And your mean BP is age appropriate target, that is 70 plus age into 2. And then your untitled CO2 target is between 4.7 to 5.3. And make sure that if the child is mechanically ventilated, you achieve the full sedation and paralysis. Of course, not every day is our day. Okay. So sometimes you need to stop the resuscitation efforts when you're going to do that. So if you gave CPR greater than 20 minutes and there are no response to your initial doses, 2 doses of norepinephrine after giving a good quality CPR, that carries a poor outcome. So that, in that sense, then you need to prepare the parents for the worst likelihood of, outcome. Of course, there is another entity, like if you suspect hypothermia, please proceed for your resuscitation until your core temperature reaches 30 degrees. Okay, don't stop the resuscitation efforts. Finally, there is another entity. Always, sometimes at some point of day, we need to have this. We have to encounter this scenario. Breaking bad news. Your efforts are futile, and we couldn't revive the child. So at that time, please remember that parents will be apprehensive. They mourn a lot, and after giving your full efforts, then how about your mental status? Then that also you need to be aware. Just try to be in their shoes, and then you need to deliver the bad news effectively. Just try to use the senior staff along with you, okay? And please offer them a separate cabin to the parents, okay, away from the bed. And then early in your delivery itself, just let the family know that child is died. Don't use any medical jargon here. Just use a simple, direct, understandable language. And if there are any questions from any family member, please answer honestly. Okay. Thank you. Any questions? Yes.
Suresh, really,
Yeah.
that was wonderful talk.
Oh, thank you, sir.
Really. Superb, sir. Then, so Suresh MVN and Suresh are pediatrician. He's really getting confused. Okay. Anyhow, sir, we have few questions here. Can we take up the questions now?
Yes, sir. Yes.
Yeah, I think one question is there. So, do we always need to wait for a specialist transport team? I think Dr. Panuganti Suresh is the right person to talk about it.
Yeah, there are certain situations where you should really not wait for the transport team, especially some neurological emergencies. If child has an intracranial bleed, you cannot really wait for a specialist transport team, and the local available resources should be used to the best possible way, and they should transport, because this is a time critical transport.
Yes, sir. Yeah, thank you, sir.
Yeah.
One more question is there.
Yeah.
Just hold on. I'm just opening. Yeah. Any specific precautions for pediatric COVID transfer? And are we anticipating exclusive pediatric COVID third wave?
We are definitely anticipating a wave, but it might not be exclusive to pediatrics, because as we look at the epidemiology over last few months, the age group which is being affected is coming down with every wave. Even during first wave, we had we had very few. During second wave, I would have seen close to 250 children with COVID. A single pediatrician seeing 250 is a big number. Third wave is going to be bigger numbers, but not exclusive. And while we are transporting that child, we should be taking same precautions or similar precautions as we take for while dealing with an adult with COVID.
Yeah, exactly, sir. Then one more question. So, what are the initial ventilatory settings in pediatric cases in the ED department? Can I take up this question, sir?
Yeah, you want me to answer, or
no? I can take this question. I can take this question.
Yeah.
Yes. So once patient has been intubated, so we have to go to the ventilatory settings. So ventilatory settings is like a complex procedure, as we know that. So we need to set many parameters. So we start with the mode. So what are the mode to be set? Then what are the, how about respiratory rate? What about PEEP? Then what about inspiratory rates? Then what about PAP? So there are many things to consider before you are going to connect to the mechanical ventilator. First, I deal with the modes of ventilator support. So if baby is premature baby, then we will go with the pressure control mode. If it is neonate, yes, again pressure control mode. If it is infant or child, yes, volume control with pressure support. These are the modes. Then we have to set with rate. So what about the rate? So rate, if it is a premature baby, 40 to 60 breaths per minute. Then if it is a neonate, yes, 30 to 40. Then if it is infant child, we start with 20, between 20 to 30. Then what about PEEP? Again, it is a premature baby, it should be 3 to 7, 3 to 7 H2O. If it is a neonate, 3 to 6 H2O. Infant and child, it will be kept between 3 to 5 H2O. Then inspirated time, premature baby 0.3 to 0.4, then infants like 0.5 to 0.6. Then PIP, for a premature baby, it should be between 18 to 22. Then for infants, it is 16 to 18. Then after selecting all these things, then we have to start the ventilator. Then we have to set the FiO2 as well. So once we connected the ventilator, we have to start with FiO2 100%, then target to the 60 or below this. Okay, that is our target of FiO2. Then IE ratio. So it will between normal is 1 to 2, 1:2 ratio, 1:3 ratio. But if there are any CO2 retention, any asthmatic patients, then IE ratio should be altered. There should be an increased expiratory time. But in case of hypoxemic patients, yes, there should be a more inspiratory time when compared to the expiratory time. Then trigger sensitivity. One of the important factors is trigger sensitivity, TI. So we have to set between 0 to -2. So if you set more than above the 0, what will happen? So what will happen means that frequency of triggering factor will be very high. So it will give frequent breath from the ventilator. You can get the frequent breath from the ventilator if you keep it more than 0. Then what happens if you keep it too negative? Means that less than -2. What will happen? It increases work of breath for the patient. Why there is increased work of breath for the patient? Patient has to trigger the ventilator. That's why you should not keep it too high. I mean, too more than 0 or too negative. I mean less than 2. These are the factors. Then major factor is tidal volume. So what is the tidal volume? So usually we start with 8 to 10 ml per kg. Then you have to target to the 6 to 8 ml per kg. If provided there is no leak. If there is a leak, yes, it should be more. It should be between 10 to 12 ml per kg. Yes. Now ventilator setting has been put. Then when to do fine tuning? Yes, we have to do fine tuning once ventilator has been set. It depends on two things mainly. One is blood gas, depends on the ABG and blood gases. Then oxygen, saturation and oxygen is. Then what are the fine tunings to be done? So two things. One for oxygenation, second one for the ventilation. So what are the things to be done for oxygenation? So you have to adjust the FiO2, PEEP and inspiratory time. And for the ventilation, you have to increase respiratory, tidal volume, then PAP, all these things. Suresh Panuganti sir, do you want to add anything here?
I think you absolutely hit on the right ones. Choosing the mode is slightly different. Means it's user biased, I would say.
Yes.
But otherwise, what you have given is absolutely right for basic settings in initial period.
Yeah, thank you, sir. Suresh MVN sir.
Yes, sir.
You just want to add anything here?
I think to give the answer, I think. No,
yeah, thank you, sir. Then one more question here. So vascular access in sick child and routes of drug administration. I can take this question. Yes, important when you are dealing with sick patient, especially hypovolemic shock patient. See, hypotension is a late sign when there is a hypovolemia. So you have to address it at the earliest when there is a hypovolemia. So you have to maintain the cardiac output, then you have to maintain the organ perfusion as well when you are dealing with hypertensive, especially to hypovolemia. So when there is a sick patient with hypovolemia, so sometimes we may or may not having the IV access. So there are clear guidelines from the PALS. So order of priority of IV access. So first one is central, peripheral lines, intravenous access. Second one is intraosseous. Then if you don't get either of these, either intravenous, intraosseous, then you have to go for the endotracheal route. Then first one is intravenous. So at least you have to establish 2 IV lines for the rapid restoration of fluids, blood products. First, you have to treat with the fluids. If not going to improve, if it is the hypertension might be due to hemorrhagic, then you have to transfuse the blood products. Then, by chance, if you are unable to access the IV line due to sick and other trauma reasons, then you have to go for the IO access, intraosseous access. So, what are the things can be given through the intraosseous? Yes, you can give almost all the things what you give through the IV line. It includes IV fluids, blood products, inotropes. Then what are the sites? First one, proximal tibia and lower end of the femur, then other fluids. Okay. So it is one of the best if you are unable to access the IV line. Then you are unable to neither of IV or IO. Then you have to go through you have to administer drugs through the endotracheal route. What are the drugs can be given through endotracheal? There is a mnemonic called LEAN, lidocaine, epinephrine, adrenaline, naloxone. So these are the drugs can be given through the endotracheal route. So as per as our false guidelines or as per our test books, then as per our experience, so this is all the priority. First IV, IO, and endotracheal. Suresh sir, anything you want to add here?
I think Suresh, I will ask Suresh sir to add anything, sir.
Yeah,
Suresh, Panuganti, sir.
just thank you. Little bit of confusion between Suresh. Okay.
Yeah, that's what I'm telling you.
So you are right. Actually, intraosseous is as good as central line. The only issue with the intraosseous being used as a central line is when you collect samples, alert the lab so that they are aware that it is a sample taken from intraosseous and not from a peripheral line. Because if there are certain bony spicules which are left, it will block the coulter, and the next day we will be getting a memo from our operations manager saying that we have blocked the machine. So for that reason, we always have to alert the lab that it is a sample taken from marrow. All the tests also can be done except blood gas and automated coulter. Otherwise, any medication, any blood product can be given through intraosseous. That's as good as a central line, can be left for 24 hours.
Yeah, thank you, sir. Thank you. Then one more question. So how to interpret and manage disability in pediatric age group? Dr. Suresh or MVN? I think you are the right person to talk about it.
Yeah. So as already discussed during the talk, we need to just prefer the standard evaluations like your EVPU scale or your GCS. And then after that, you need to check the pupil response and then just quickly measure the blood glucose test too. So altered level of consciousness in children, majority, you need to just emphasize the factors why child was altered. So majority like the causative factors would be like pure cerebral perfusion, could be due to severe shock or traumatic brain injury, or due to encephalitis or meningitis sometimes, or drugs or hypoxemia. And sometimes we generally miss or we quickly need to check the BM, that is blood glucose. So, and if due to the, increased metabolic demand, sick child tend to have the low blood glucose levels. So try to quickly correct it, and then try to correct the hypoxemia as well as the hypotension. There, I think you can increase the perfusion, and then I think that would be the right management approach. Right, sir? Suresh, sir, anything to be added?
Yeah, actually, like you pointed during your presentation, we don't really need to memorize the pediatric GCS score because it's not practically possible to keep a track of whether child is cooing, babbling, and all those things. We can use AVPU as a surrogate marker just for information of postgraduates. On a scale of AVPU, if child scores A, it's as good as GCS of 15. If child scores B, GCS is equivalent to 12. P on AVPU is equivalent, GCS score is 8, and the U of AVPU is equivalent to 3. This is a easier way to remember 15, 12, 8, and 3 for AVPU. And like you said, it's better to keep it in the pediatric way and refer rather than memorize.
Yes, sir.
So, sir, last question, sir. Suresh Panuganti, sir.
Yeah.
So there is one question. In case of severe electrolyte imbalance, mostly hyponatremia, proper way to manage an emergency. These are questions by one of our viewers. Sir.
Okay. If it is symptomatic hyponatremia, we can give a bolus of 3% saline, 5 ml per kg of 3% saline. If it is symptomatic hyponatremia, if the child is asymptomatic and sodium is level, we shouldn't be chasing to correct it rapidly, because not only CPM, there is something EPM, extrapontine myelonosis also can occur, which is not a common one, but it is similar to acute onset Parkinsonism. So if child is not symptomatic, do not chase and give bolus. If child is symptomatic, like child is throwing seizures, don't shy away from giving 3% sodium chloride. It is pretty safe. 5 ml per kg, we can give it straight away.
Yeah, yes.
Sir,
So with this,
sir, there is another question to panelists here from Raja. There is what are the mask recommendations for pediatric age group? Suresh, sir, anything?
So if it is for patients beyond 2 years, yes, there is an absolute recommendation to wear mask. If we are talking about protecting one's own self, or if you are talking about resus, there are masks. You don't have to memorize the size of mask for each age group. The best way is to put it on to the child's nose and mouth without crossing the chin and without compressing on the eyes. That's the best way. Anatomical masks are slightly better so that they have a better fitting and slightly lesser chance of leak. And the cushioned masks are better, which can be cushioned with air.
Okay, sir.
yes, sir. Thank you, sir. So thank you, Dr. Suresh MVN, sir. Thank you, Dr. Suresh Panuganti, sir, for enlightening about how to transport a sick child, then how to deal sick child in emergency department. Thank you, sir. Thank you, one and all. Thank you, all the viewers.
Sir, thank
you
for
very much for
moderating. Yeah,
Thank you, sir.
Yeah. Thank you very much.
Thank
Thank you, everyone.
Thank you.